about angiodysplasia. So basically, guys, angiodysplasia is basically like over here they have a question, right? What is the likely diagnosis for adult for an adult with episodic painless dark maroon colored stool? So that's going to be angiodysplasia. So typically it's going to be right-sided, which is going to be versus diverticulosis, which is typically left-sided. And with the passage of bright red red blood arterial and anemic are going to be treated with cautery. So this is going to be undergoing the cautery. So that's going to be the treatment. So we can see the procedure that uses heat from electric current, and that will destroy any sort of abnormal tissue or lesion. We can see we have a sample question over here. So we can see a 67-year-old female with 2-month history of perirectal pain that worsens with bowel movements and thick yellow rectal discharge, and rectal exam shows brown stool, posterior perineal walls, erythematous, draining sinus tract. What's the diagnosis? It looks very Crohn's disease like, yeah. So because Crohn's disease, you're gonna have inflammation of every single layer. So when we're gonna get inflammation of every single layer, essentially we're gonna be getting fistulas. So that's a really key high yield point which I want to mention over here. All right, so then we can see a patient with angiodysplasia are more likely to bleed if they have what other coexisting morbidity. I think that's aortic stenosis. So sorry, it's end-stage renal disease 1 we run aortic stenosis. So pathogenesis low yield but inflammative. So this is a low yield point. So we can see that aortic stenosis or aortic valve placement, essentially aortic valve is like this, but when you get a like stenosis, it becomes a little bit like this, and that will lead to shear stressing, cleaves the Waldron multimer. So this means decrease platelet activation, and there's going to be more amount of bleeding. So this is Heinz syndrome. We can see von Willebrand factor normally suppresses angiogenesis. And we can see decreased von Willebrand factor that's going to lead to increased angiogenesis and angiodysplasia. So we can see this over here. So you're going to be with shear stress cleaves the von Willebrand factor. That will lead to decreased platelet activation. That leads to more amount of bleeding. We can see colovesicular fistulas over here. The colovesicular fistulas, these are going to be between your colon and your urinary bladder. We can see clinical features of colovesicular fistulas is going to be diverticular disease, so sigmoid most common, or Crohn's disease, malignancy, colon, bladder, and the pelvic organs. We can see clinical presentation is going to be air in the urine and fecal urea, so stool in the urine. We can see recurrent urinary tract infection, mixed flora. So we can call this fecal urea, so basically feces within our urine, or we can see nematuria, basically means air in our urine. So we can either get feces in our urine, which is abnormal, or air in our urine, which is also abnormal, like kind of like flatulence. It's going to be that, but in the bladder. We can do a CT scan of the abdomen. We can do an oral or fecal contrast colonoscopy to exclude out colonic malignancies. We can come over to toxic megacolon. So toxic megacolon is going to be caused by C. diff colitis. So one of the risk factors is going to be any type of situation where you're getting more bacteria. So older because you're immunocompromised. Okay, antibiotics, because antibiotics you destroy the good bacteria, so you get more proliferation of unhealthy bacteria. Proton pump inhibitors, you're going to be destroying your acid, so more bacteria. Okay, immunosuppression, okay, chemotherapy, okay, or IBD, okay, all of these good stuff. Okay, and all recent antibiotic exposure, which I did mention, and hospitalization, maybe because of exposure. Okay, we're gonna get profuse water diarrhea, guys, but there is one apparent question that shows up on some CMS form that you get blood diarrhea with C. diff, but 99% it's water diarrhea. Your leukocyte count is around 14,000, so normally a leukocyte count should be between 4,500 to 11,000. Over here it's slightly elevated, like 14,000, so it's slightly 15,000. Okay, we can see fermenting colitis or toxic megacolon, which can be like quite enlarged, which is a complication. How you want to diagnose the stool PCR for the C. diff? You want to do a C. diff toxin assay, so we can think about some toxin assay if we're also considering that as well. So we can see PCR for C. diff genes, and then enzyme amino acid enzyme amino assay. So that can be the enzyme binds to toxin A and B and emits a fluorescent. We can see for glutamate as well, and then we can see where. Guys, I have a question for you guys over here. 28-year-old male with ulcerative colitis, blood diarrhea, but it resolved. And he has a lot of watery diarrhea, and leukocytes 16,000, neutrophils 80%. What's the diagnosis? It means C. diff colitis. They can be very, very tricky, where his stool testing for C. diff gene or C. diff toxin and all this good stuff. Okay, in fact, how do you want to treat this? Infection control, oral hygiene, soap, water, contact sporicidal disinhibition with bleach. It can be warm, but can be bloody too, which is going to be here. Genes are going to be specific to toxigenic RSS. Guys, treatment, I want you guys to give oral vanco, not IV, oral vanco and oral fidazomicin. Fidazomicin can be there for treatment if it's, yeah, so that's going to be here.